next lecture, AI in chest X-ray interpretation in pediatric ICU. Does it add certainty or confusion? دكتور جورج عزت مدرس الأشعة التشخيصية بطب عين شمس.
Good morning, everyone. Our topic is about artificial intelligence and chest X-ray in interpretation of pediatric intensive care patients. Does it add certainty or confusion? I would like to thank Dr. Shamar Sattar and Dr. Maha Arafa. That was actually a thesis for master for then resident Dr. Maha Arafa. And that's her presentation actually, but she isn't here to present it, so I'm presenting it instead of her. Chest X-ray represents 40% of all radiological exams. If AI can help with a certain study, it will be always chest X-ray to reduce the workload for the radiologists. Chest X-ray radiological abnormalities include change in the appearance of normal structures, increased radiolucency, and abnormal radio opacity. Here are examples of some abnormalities. In our study, we used Lunit Insight Chest X-ray software. It's a model used by the Ain Shams University hospitals for chest X-ray interpretation. It has a South Korean manufacturer and has been commercially available since June 2020 and trained over 200,000 cases. This study was done actually in 2021, so I'm sure there are much more advanced models by now. And Dr. Aya can tell us about that after that. This software actually produces three types of results. First, it produces a probability score or an abnormality score of the entire chest X-ray study, whether it's abnormal or normal. Then it produces a heat map for the abnormality, and the degree of color reflects the probability of the abnormality. And lastly, it produces a report with the different findings and the probability of each. We'll see examples of that later. The aim of that study was to test diagnostic performance of Lunit Insight Chest X-ray in PICU chest X-ray and investigate the effect of AI on specifically residents' performance in chest X-ray interpretation. The study type was done in pediatric ICU patients in Ain Shams University, and 30 patients were included. The inclusion criteria was chest X-ray of pediatric patients admitted to PICU. There was clinical data available for each patient, and the age range was from 1 day to 16 years old, and we excluded any images with poor image quality or poor positioning. There were 5 image interpretations for each chest X-ray. One by the AI alone, one by the resident alone, one by the resident after 2 weeks with the help of AI. There was also a consultant radiologist who interpreted the images once by himself and once with the aid of AI. So there were 5 interpretations. There are 10 points that this AI software looks for in any chest X-ray: consolidations, pleural effusion, fibrosis, cardiomegaly, mediastinal widening, atelectasis, pneumothorax, pneumoperitoneum, nodules, and calcifications. all data was tabulated and statistically analyzed. We tested the sensitivity and specificity of the AI, the changes in the diagnostic sensitivity and specificity of the resident after the aid of the AI, the changes in the agreement degree between the resident and the consultant radiologist with and without the AI, and the effect of AI on time consumed for interpretation for both the resident and the consultant. This software had very good sensitivity for most of the tested findings, except for atelectasis and pleural effusion, which was relatively lower. The problem was in specificity, especially in some findings, which we'll discuss later. We can see in this graph the difference between the performance of resident with and without AI sensitivity. In most findings, there was increase in the sensitivity of the resident to pick up findings after using the AI. And there was also increase in the degree of agreement between the resident and the consultant radiologist after the use of AI. Also, the mean time for interpretation after for each study was significantly reduced after the using of the AI software. And finally, we came up with a proposed cutoff point for this software for the probability score, after which we can diagnose this abnormality. We proposed over 60% in consolidations as a cutoff value for diagnosis of consolidations by using the AI software. Examples of some cases: a 4-month-old male admitted by chest infection, a non-cardiac patient. Chest X-ray, as you can see, shows cardiomegaly with bilateral pulmonary congestion and left upper lobar consolidation. The AI did very well, actually. It picked up the cardiomegaly and picked up also the left upper lobe consolidation with a heat map indicating high sensitivity. But the problem is it picked up also a right upper lobe consolidation, which is kind of equivocal, but it showed it in a lower probability. So this will need confirmation by a consultant radiologist. In case 2, we can a 5-year-old cardiac patient with history of hospital admissions due to recurrent chest infections. After admissions, the child developed oxygen desaturation, and his conditions required PICU. Chest X-ray shows bilateral consolidations and the bilateral upper lobar fibronodular pattern. Also, there was a right upper zonal calcification and mild cardiomegaly. This was a case with multiple findings, and actually the AI did well and picked up most of the findings. It showed the bilateral consolidations and the cardiomegaly and the reticulonodular densities, as well as the right upper zonal calcification. In this case, a 7-month-old female admitted with severe pneumonia underwent intubation with no improvement. In the chest X-ray, there is bilateral pneumothorax and right faint consolidation, as well as right mild pleural effusion. We can see that the AI did very well in the pneumothorax with certainty of 75%, picked up the bilateral pneumothorax, and picked up also the right-sided consolidation. Pleural effusion had a poor sensitivity in pleural effusion, especially mild pleural effusion. In this case, there is a 2-year-old male neonate admitted to ICU due to respiratory distress, for which he was intubated, and the child developed decreased air entry. We can see that there is a right lung diffuse confluent consolidations, left pneumothorax, and rim of left pleural effusion. The AI picked up the pneumothorax with certainty of 94%, picked up the consolidations on the right side with a good probability score, and the pleural effusion, as always, the probability score was a little less certain than the rest of the findings. In case 5, this is a 10-month-old infant with severe respiratory distress and with no improvement after intubation. Chest X-ray shows bilateral consolidations and right-sided pneumothorax. I don't know if you can pick it up from here. There's right pneumothorax and bilateral rickety rosary. Actually, the consultant radiologist missed this right pneumothorax and could only see it after the AI pointed it out. And there was also right-sided consolidations and cardiomegaly. I was expecting in this case that the AI would misdiagnose the rickety rosary as pleural effusion or any other abnormality, but it actually didn't. It didn't misdiagnose the rickety rosary at all. To summarize, this Lunit chest X-ray software was the best finding in detection was pneumothorax. It was both sensitive and specific. In consolidations, it is highly sensitive but less specific and needs confirmation by consultant radiologists if the probability score is less than 60%. But it's, we found in other cases, not in this presentation, that it sometimes overestimates neoproteinaum when there isn't any neoproteinaum, and that needs to be excluded by an expert radiologist. In conclusion, effective implementation of deep learning model has the potential to improve radiology residents' clinical practice. There is a possibility for potential use of AI systems in the future radiology workflows for preliminary interpretations that target the most prevalent findings, leaving the final reads to be done by a more experienced radiologist. Recommendations is for studies to be done on a larger number of cases to be included in the study. More comprehensive study by a larger pool of radiology residents and experts, because this was only done by one resident and one consultant radiologist. And another modality to confirm the findings, like CT chest, to confirm the findings of both the AI and the radiologist. Another recommendation is also to repeat the study with more advanced model, because this is an outdated model in 2021. Thank you.
استاذن حضراتكم عندي كومنت. جورج، انت في الريكومنديشنز بتاعتك you suggested ان احنا نعمل larger study على larger number. هو احنا actually في عندنا CE and FDA approved software موجود في الدمرداش اللي هو Cure AI. فيعني لو انتوا حابين تكملوا يا ريت، الحالات موجوده و it's already run. يعني هو دلوقتي it was run about على حوالي 70,000 حاله في study تانية حد معانا في الاسم برضو. if you can compare this to the results you have, I think this would be beneficial. ونستغل الفرصه نرحب بدكتور ايهاب خيري رئيس اسم الاطفال. مشرفنا حضرتك والله بجد. ثانك يو. يا ريت تفضل معانا بقى عشان نسمع فيدباك بتاع، لا عايزين نعرف وجهه نظر حضرتك والله بجد يعني كلينيشنز.
Good morning, professors and colleagues.